Thank you, Mr. Chairman, for your nice introduction, and I will start by a short story of a female, 16 years, presenting with end-stage renal disease. A renal biopsy was taken and revealed that she has end-stage renal disease and thrombotic microangiopathy. She went to Mansoura Nephrology and Urology Center and came back with a report about her end-stage renal disease secondary to atypical hemolytic uremic syndrome due to genetic abnormalities in factor H and I and complement factor 3 deficiency, and the incidence recurrence after kidney transplantation in such cases is around 60 to 80% unless transplanted in centers where anti-C5 monoclonal antibody eculizumab is available and administered before and after transplantation. So what is exactly the story? The first description of atypical hemolytic uremic syndrome was done by Gesser et al. In 1955, and he described this disease as a self-limited illness associated with a prodrome of diarrhea that results in spontaneous recovery. Hemolytic uremic syndrome is a microvascular occlusive disorder that belongs to the category of diseases known as thrombotic microangiopathies, and hemolytic uremic syndrome is characterized clinically by microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. We have two main types of hemolytic uremic syndrome. The typical hemolytic uremic syndrome diarrhea associated with each is present in 90% of cases, and the atypical hemolytic uremic syndrome diarrhea negative from 5 to 10% of cases. Typical hemolytic uremic syndrome usually occur in young children from 6 months to 4 years and after GIT infection caused by Shigella toxin E. coli strain 0157 or Shigella dysentery serotype 1, and atypical hemolytic uremic syndrome occurs at any age and caused by non-enteric infections, complement dysregulation, coexisting diseases, drug-induced or idiopathic. We have etiological classification of atypical hemolytic uremic syndrome, which may be genetic, complement factor H mutation, complement factor I mutation, membrane cofactor protein, thrombomodulin mutation, Van Willebrand factor deficiency, ADAMTS13 deficiency, or infection induced by Shigella toxin E. coli, Shigella dysentery, HIV infection, or associated with other diseases as systemic lupus, antiphospholipid antibody syndrome following organ transplantation, malignant hypertension, glomerulonephritis or HELLP syndrome, and drug-induced as in calcineurin inhibitors, cyclosporin or tacrolimus, cytotoxic agents, mitomycin C or cisplatin, antiplatelets, ticlopidine or clopidogrel, quinine, or oral contraceptives. And investigations which will be done for cases of atypical hemolytic uremic syndrome, plasma level of complement 3, complement 4 level, anti-complement factor H autoantibodies, complement factor H, complement factor I, and complement factor B. Decreased complement 3 level can be observed at acute phase of Shigella toxin E. coli HUS, and decreased C3 level are observed in only 30 to 40% of patients with atypical HUS. Thus, a normal C3 level does not rule out a diagnosis of atypical HUS. And decreased complement factor H or complement factor I plasma level are observed in about 50 and 30% of patients with mutated complement factor H or complement factor I, respectively. Thus, normal complement factor H and the complement factor I plasma level doesn't rule out a diagnosis of atypical HUS. This is the pathology of a patient with atypical HUS, showing in this figure proliferation of endothelial cell and obliteration of the lumen and thrombosis of an arteriole. Atypical hemolytic uremic syndrome is a rare disorder characterized by overactivation and dysregulation of the alternative complement pathway. Estimated prevalence 1 to 2 per million, and it has more severe course. Atypical HUS has more severe course compared to typical infection-induced HUS, and is frequently characterized by relapses that lead to end-stage renal disease. For a long time, kidney transplantation for these patients was contraindicated because of high rate of recurrence and subsequent renal graft loss. The alternative complement pathway is persistently activated in plasma, and this activation is usually minimal and leads to minor attacks on structures that the final complement product comes in contact with. Under normal conditions, this process is very well regulated by regulatory complement factors, and the alternative complement pathway is activated by spontaneous hydrolysis of complement factor 3, and the complement factor 3 after hydrolysis will be transformed into complement factor 3b, and this in conjunction with BB resulting from action of complement factor D over complement factor B, and the result into 3BBB, which is complement 3 convertase. And this complement 3 convertase will be auto-regulated and results into C3BBB3B, which is a complement factor 5 convertase, which acts on complement factor 5, resulting into complement factor 5B, and its interaction with complement from 6 to 9 result into membrane attack complex, which acts on endothelial cells, resulting in lysis of the cell and platelet aggregation and the formation of microthrombi. Mutations affecting complement regulatory factors as complement factor H, complement factor I, membrane cofactor protein, thrombomodulin, complement factor B, and C3 result in activation of the complement system and results in associated atypical HUS risk after kidney transplantation. Complement factor H occur in atypical hemolytic uremic syndrome in about 20 to 30% of patients, and the risk of recurrence post-transplantation was 70 to 80%. Membrane cofactor protein occur in 10 to 15%, and it has a very low incidence of recurrence after transplantation. Complement factor I from 5 to 10%, and its recurrence was high, about 70 to 80%. Thrombomodulin occurs in 3 to 5%, and it has probably a very low incidence of recurrence after transplantation. The recurrence risk, if high, risk from 50 to 100%, previous early recurrence, pathogenic mutation, or gain of function mutation. Prophylactic eculizumab is essential. Start on day of transplantation due to potential or for severe recurrence and the limited recovery of function in renal grafts compared with native kidneys. If there is a moderate risk, prophylactic eculizumab or plasma exchange. Low risk, no need for prophylaxis, which may be associated in patients with isolated membrane cofactor mutation, persistently negative family history autoantibodies. Post-transplant atypical hemolytic uremic syndrome recurrence triggers: old age at the presentation, short duration between onset of disease and end-stage renal disease or transplantation, use of living donors, and use of calcineurin inhibitors are all associated with high risk of recurrence. And it has been suggested that recurrence after transplantation may be less common among patients who have undergone a nephrectomy prior to transplantation, and there are different mechanisms in kidney transplantation process that may trigger recurrence after transplantation, including brain death-related injury, ischemia, reperfusion injury, infections, and use of immunosuppressive drugs and rejection. There is growing evidence about the role of complement activation in brain death-induced organ injuries, which could be a trigger for atypical hemolytic uremic syndrome. Decision making is genetic study, risk assessment for post-transplant atypical hemolytic uremic syndrome recurrence, preemptive plasma exchange and post-transplant plasma therapy, kidney liver transplantation or isolated kidney transplantation, availability of post-transplant medications, and finance, as we know that eculizumab is a very expensive drug. The availability of post-transplant medications, plasma exchange, rituximab, eculizumab, and plasmapheresis. I will talk about plasmapheresis in patients with atypical HUS. Earlier studies did not show good outcome with plasmapheresis alone in the treatment of post-transplant atypical HUS recurrence. Nori et al. Reported that plasma therapy induced remission in 55 to 80% of episodes in patients with complement factor H, C3, or thrombomodulin mutations or autoantibodies, whereas patients with complement factor I mutations were very poor responders. Earlier reports of successful treatment with plasma in atypical hemolytic uremic syndrome date back 30 years, and since then plasma exchange or infusion has been associated with a decrease in mortality from 50% to 25%, and the guidelines suggest that plasma therapy should be started within 24 hours after diagnosis with an exchange of 1 or to 2 plasma volume exchange. And since complement factor H is a plasma protein, plasma infusion or exchange provides normal complement factor H to patients with homozygous mutation and complete complement factor H deficiency and induces disease remission. The beneficial effect of plasma strongly depends on the amount, frequency, and the method of administration, with plasma exchange having been shown to be superior to plasma infusion for remission and prevention of recurrence, possibly through the removal of mutant dysfunctional complement factor H mutation. Plasma exchange appears to be effective in removing anti-complement factor H antibodies. However, the effect is usually transient, and the combination of plasma exchange with the use of immunosuppressive drugs as corticosteroids, azathioprine or mycophenolate, and anti-CD20 antibody rituximab resulted in long-term dialysis-free survival in 60 to 70% of patients. And patients with complement factor I mutation have only partial response to plasma therapy. In this study of 205 patients enrolled in Vienna thrombotic microangiopathy cohort, preemptive plasma therapy prevents atypical hemolytic uremic syndrome relapse in kidney transplant recipients, and preemptive plasma therapy prevents atypical hemolytic uremic syndrome in patients in kidney transplant recipients. Future therapies in this concern include concentrated complement factor H, which is purified from human plasma, and also recombinant thrombomodulin can be utilized in the treatment of atypical hemolytic uremic syndrome. And I will finish my talk here to present my colleague, Professor Dr. Ashraf Fouda. He will continue his talk about renal transplantation for patients with atypical hemolytic uremic syndrome.